Good morning. Happy Friday. Welcome back to Instagram Live. Sorry, we are definitely having some technical issues this morning. Dr. Miguel Medina from Miami Cancer Institute joining us this morning as many questions have been asked and we're going to get some answers. Obviously, these calls are no medical advice given, but, just coming on and being aware of your breast reconstruction options is imperative. Yesterday was International Flat Day, and we definitely brought some awareness to that, as flat closure is an anesthetic. Flat closure is an option for women. So thank you so much, and just bear with us as we are waiting for Dr. Medina to join. I'm going to invite Dr. Medina again. Just bear with us as we are waiting. Perfect. So again, for those of you who don't know me, I'm Tracy, the founder of BRCA Strong. And one of my goals is to make sure that we go ahead and educate women on knowing your breast reconstruction options. I found out at the age of 21 that I carry the BRCA gene mutation, and definitely technology has advanced enormously and changes have been made in our community. And that's one of the reasons I find it so imperative to share what your options are and knowing who is available in your area to do that. Again, it is so important to know your options, to be aware of what is available. Many of us don't even know that there's options out there. Good morning, Dr. Medina.
Can you hear me now?
I can. How are you?
Perfect. Good morning. Thank you for having me.
You're welcome. It's really funny. I was talking to Susan from Suma Inc. yesterday, and we decided that you were the one who broke the internet on Monday because so many people wanted to be on the call. So we're like, Dr. Medina did it. That's it. He had to go in the OR and just shut all the
Yeah,
internet
shut it
down.
down.
How are you?
I'm good. Thank you. How are you?
Good. So, I was just telling everybody we're on this morning, just having a basic conversation, and questions are welcome, about breast reconstruction options. As you know, one of my goals is to always educate and let women know what's going on, what their options are in the community of breast reconstruction, because I feel like there's no gold standard and there's a lack of information out there for women who are going through this. It's bad enough our survivors have to go through treatment and go through radiation and then, face the plastic surgery side and not have all of your options given. So if you want to take a second just to introduce who you are, and again, Dr. Medina is from Miami Cancer Institute, which is one of our sponsors, is we have an amazing multidisciplinary system right in our backyard where all of our physicians are together under one roof, which really makes it easier for patients, as when you go through any diagnosis, you can see physicians all in one system.
Well, thank you very much for having me. I did my training in plastic surgery in the Harvard program in Boston. We're always a very breast reconstruction intensive program. And then I spent a year of additional fellowship for advanced reconstruction and microsurgery at Johns Hopkins. And I was in practice for a while at the Cleveland Clinic here in Florida. And then I was recruited to come over here and start the plastic surgery program. And I've been fortunate to become now the chief of the plastic surgery program here at the Miami Cancer Institute. And we have a very integrated breast cancer program between oncology, radiation oncology, surgical oncology, and plastic surgery. And you're absolutely right. Breast reconstruction is very complicated. And I always tell my patients, obviously, the most important thing to do is to get you cancer free. But the most complicated part of this procedure and this experience is usually the breast reconstruction. And there is no one size fits all breast reconstruction for patients. So there's a lot of options, and some patients have a lot of options, and some patients have very few options. And it gets very down into the weeds, if you will, as far as what's appropriate for each patient and what's the sort of best way to go.
And, when we talk about this, you said different things that I'd like to kind of back up. A lot of women don't even know about the flaps and about, physicians need different credentials to do them, right? Like an autologist reconstruction, right? Did I say it right?
That's right. Autologous reconstruction, and autologous reconstruction in of itself comes in different flavors. But the one that most people tend to think about these days is the deep flap. And the deep flap is a very elegant solution to breast reconstruction, but it definitely takes a different skill set from your average reconstructive surgeon. And so we have three microsurgeons, and two of us are fellowship trained microsurgeons. And we philosophically believe that to do microsurgery really well, a team approach is important. And so we always have two microsurgeons in our microsurgical cases. It lowers operative times, it lowers complication rates. I think it's much better for patients, and we've published that, and other places have also published that as well. So I think additional qualifications for things like deep flaps is important.
Maybe we could back up a little bit and just start at like, so one thing that I really would like to, stress a little bit is anesthetic flat closure is an option for women as breast reconstruction. And I think often it's not offered to women. And as I'm learning personally as the founder, like I see so many more women who are talking about it, and people are like, how can you consider that a reconstruction option? So maybe you want to answer, like, how do we consider that a reconstruction option from your side? Because it's still, how does that work?
Yeah, so I think that's an excellent point. And the pendulum has swung kind of the totally opposite direction these days. If you talk to surgeons and patients in the 90s, there were a lot of flat closures, and a lot of patients weren't referred for reconstruction. And so we've gotten a lot of good education and a lot of momentum for offering reconstruction, but it's gone the other direction, in which I think there's a subset of patients that feel like they're obligated to get reconstructions, and that may not be the right choice for them. I think that reconstruction is a very personal choice, and it may not be appropriate, or you may not want it for everybody. So I think aesthetic flat closures are important to offer, and to reassure women that this is your personal choice, and that you don't need to feel obligated to have a breast reconstruction because other people have offered it to you.
And I think, feeling obligated, like going through this process, right, as it takes an emotional toll on us, major decisions, if we're married or we have better halves, or if you're alone and single, or, I think that is a huge part of, knowing your options and getting that guidance. Because again, not everybody wants implants. Not everybody wants to have a flat procedure. Some women just want to be flat, and it's become more popular and more prominent, I think, in our community. So, that's obviously one breast reconstruction option, but, maybe we can go into a little bit of what your options are for breast reconstruction. And
Right.
like when you see a patient, for example, what do you offer a patient? How does that work?
So the first jumping off point is the discussion between autologous, meaning use of your own tissues, versus implant-based. And then there are some hybrid using your own tissue and implant operations. That is largely called the latissimus dorsi flap, and that in most settings is a backup or a salvage flap. So your first option is whether or not you want to use your own tissue, and that comes in a couple of different reasons for that. One, there's a subset of patients that are not interested in prosthetics. Simply, they don't want a foreign body in their body. The downside of having a breast implant is that once you have a breast implant, you more than likely have another operation waiting for you, be that an exchange for a rupture or a malposition or a capsular contracture. We call these permanent devices, but they're not permanent devices. They obviously have a lifespan. That lifespan tends to be somewhere in 10 to 15 year range. As the newer implants have come on the market, we've seen what they appear to be lasting longer, but they officially came back on the market between 2005 and 2008. So you're only getting to 15-year data right now on the new implants. And we certainly see problems with implants that show up within a couple of years. And I have patients who've had implants from the 90s who haven't had any issues at all. So an important thing to discuss with implants is I don't believe in programmed replacement of the implant, meaning that just because your implant is 10 years old and someone tells you, oh, your implants need to be exchanged, that's not necessarily true. If the implant is intact, the pocket is soft, you're happy with the shape, you shouldn't just remove it by age. It's just that at that age, that's when issues start to arise. Exchange of implants tends to be well-tolerated outpatient procedures. I mean, we joke a little bit because we have a subset of patients that come in their 80s with a ruptured implant or a contracted implant. And my first option is always to, okay, you want to just get rid of everything? Do you want to go to a flat closure now? And most of my patients look at me like I'm nuts. Like, no, I want my last set of implants, they joke. So that's not to trivialize going back to the operating room, but most people tolerate an exchange well. Now, there is a subset of patients that do not appear to tolerate implants, and this implant-associated illness, associated illnesses. And I do believe that is a real entity, and I believe that that's a complicated entity because it's a low percentage entity, meaning that it's hard to study, and so the medical literature has always been a little controversial with this. We have absolutely had patients who've had issues with joint pain, muscle pain, tendon pain, in which we have removed the implants and either gone to a flap or gone to a flat closure where those issues have resolved. There's also a subset of patients that you remove the implants and do those operations and they don't get better. So implant-associated illnesses are real, but they're complicated. The other option is flap reconstructions, and flap reconstructions make a beautiful breast. I mean, they do a very good job. You have an all soft tissue breast, but it's a big investment on the patient side in going to a flap. So in general, implants tend to be easier recoveries, but the penalty for that is dealing with them later. The flaps tend to be much longer recoveries, and you're healing two sites, but the upside of that is that once everything goes well and you've done a little touch-up procedure, then you really don't ever have to think about it again. And so you can make a very nice breast with a deep flap. Here we have a very focused deep flap harvest in which we try and preserve all the nerves. If we have to cut a nerve to raise a flap, then we sew those nerves back together, because the issue with deep flaps, and the reason that deep flaps exist, is that the way people used to do this is what was called a pedicle tram flap, in which the abdominal muscle was maintained attached to the tissue of the tummy so that that brings the blood supply. The deep flap is really a transplant of tissue, just like a kidney transplant or any other type of transplant. That the tissue is completely removed from the body and it is reattached under a microscope, the blood vessels, back to blood vessels in the chest. So when you do that, you have to violate that abdominal muscle in order to remove the blood vessel intact. And when you stretch that muscle or you cut those nerves, you end up with weakness of the abdominal wall. You can end up with hernias or bulges that need to be dealt with later. And so that tends to be the more common problem with the deep flap, is making sure that you leave a good intact abdominal wall here, and we try to really spare all the muscle, and we really try and spare or repair any nerves that are involved with the harvest of the flap. The dread is always a problem with the connection to the flap. And in experienced microsurgery centers, failures for flaps tend to run in the anywhere from the 1% to 2% range. So the failure rates, even though it's what we worry about the most, tends to be a lower percentage problem than making sure that we have a good, strong abdominal wall after the flap. And that's the trade-off. Pedicle tram procedures are actually good procedures, but they're not good for two breasts. So if you have to make two breasts, then it would involve using both the muscle abdominal wall, and then you've really left the abdominal wall with muscular strength. For one-sided breast, the data is actually kind of equivalent between deep flaps and pedicle tram flaps, because you can reorganize the muscle of the abdominal wall, and you can strengthen the abdominal wall if you have one ab muscle in place. But if you take both of them, obviously you've really changed the function of the abdominal wall. So the deep flap is really the best for someone who wants their own tissue and wants to make two breasts from it.
We have a lot of women say to us that they're not candidates for a deep flap. Are there other flaps that they can consider? I mean, we talked about latissimus, and I know there's some new ones. Maybe you just want to touch a little, base to educate the women.
The workhorse flap is the deep flap, in part because it's just good tissue for breast. It really replaces very similarly the softness, and you can shape it well for a breast. So that's why it's the number one. But we definitely have patients that are like low BMI patients that are thin, patients that have had, let's say, a tummy tuck in the past and they don't have that tissue available. There are options to go to thigh tissue and some hip tissue, and that would be sort of the next choice for a no implant breast reconstruction. So some of these are called Pap Flaps or tug flaps, and those are largely based on the inside of the thigh. Now, the issue with those can be that those can have a smaller amount of tissue. So to make one breast, you might have to put two of those flaps together. What you hear about is called a stacked flap, where you're going to take two flaps, you're going to connect them to each other, and then you're going to connect them to the body. Those are definitely sort of a higher level, varsity type microsurgery, if you will. And we do those too, and you do those in sort of cases in which you don't have an abdominal donor site. Patients really don't want an implants, or they've had complications with implants. The other things are patients that have had, a breast reconstruction patient may or may not have the option to do an implant based on what's happened in the breast in the past. So patients that have had, let's say, radiation therapy and lost their breast reconstruction, you're no longer a candidate to place a tissue expander in. That radiated skin just won't stretch. It'll lead to exposure or loss of that device if you try, for the most part. So you need a flap to cover that. And so those patients are usually primary flap candidates, where you want tissue from the tummy or the back. And if they don't have tummy tissue, the back is a good option. But the back tissue requires an implant, which is what makes it a compromise. And that's because the back tissue is just too thin. So you bring some skin from the back and you bring the muscle from the back, and you can do things like fat grafting and thicken that muscle and make it softer. So for a small breast, you may still be able to get away without an implant. But in general, that latissimus flap requires an implant, or you're talking about taking thigh tissue or sometimes buttock tissue as well. The buttock tissue was used more often before these thigh-based flaps happened. These are the S-gap and I-gap flaps, where you usually take a piece of tissue from the top of the buttock. The problem with that tissue is it tends to be very fibrous fat. It seems to be much more structural fat. So unlike the tummy tissue, which is almost like putting a breast implant in the pocket, the buttock tissue is very firm. And so shaping it in cosmetic outcomes are more complicated with buttock tissue.
Can you explain, a couple women have asked, like, why are MREs ordered and what are they? As women are entering the process, women don't understand why we need scans or what this scan shows.
Yeah. So on the breast cancer side of things, the MRI is very, very effective at showing cancers that don't show up by mammogram or ultrasound. So by far the best imaging study for breast cancer MRI. Now you ask, well, why doesn't everyone just get an MRI from the beginning? And that has to do with healthcare costs. The MRI machine is expensive. It's also a more invasive study for the patient, in that you have to be in the MRI tube for 30 minutes, 40 minutes. It's not the most comfortable experience for some patients. If you're claustrophobic, you're not going to love the MRI machine. But that is the best for diagnosing things, or making sure that, so let's say a patient comes in, they have a breast cancer on one side, their genetic testing is negative, but they have a small lump on the other side. You want to make sure that you're not looking at two breast cancers, or that there's not something in the other breast. The MRI is very good for that, and you've already reached the level of concern where you know that this is someone that needs more advanced screening. So that's MRI on the oncology side of things. For flap surgery, we also use MRI. And so patients that are worried about going into a CT scanner or getting a radiation dose from the CT scanner, or don't tolerate the dye used in the CT scanner for looking at the blood vessels, the MRI is an option. The MRI uses no radiation. It's a giant magnet. So it takes more time to be in the MRI machine, but the trade-off is no radiation. The CT scanner does give you a dose of radiation. It's a very low dose. It's a safe dose, but it is a dose of radiation. The CT scanner is faster and an easier study, if you will. So most of us, when we're looking at blood vessels for deep flaps, we use a CT scanner so that we can plan operatively where we know that blood vessel is going to be. But the CT or the MRI can be used for that.
Yesterday we had Susan from Suma Inc. on, and a couple of questions came up about thin skin, and is it safe after you have reconstruction or flat closure to have nipple areola tattooing? And Susan said she was going to turn over to Medina this morning. She wasn't going to answer that.
She's wonderful, and she's done some just amazing work for our patients. So she's been a huge addition to our team. And nipple reconstruction kind of becomes its own other question. A lot of patients go through this and they're kind of ambivalent about nipple reconstruction at the end. And I tend to encourage nipple reconstruction. I think nipple reconstruction is transformative. And you see that patients' relationship to their breast changes after nipple reconstruction. You really start to look at it and you say, oh, this is my breast now, instead of, oh, this is my reconstruction, and it looks okay. And I've had even results that I would consider as sort of average results that I wasn't thrilled with. And then we did a nipple reconstruction, and it changes it. You look at it and you're like, oh, no, actually it looks pretty good now. And it's just, it changes the way your eye interprets what it's seeing. The breast, with a nipple on it, looks like a breast. And she does these amazing 3D nipple tattoos. So I think nipple tattoos in general are options for all breast cancer and breast reconstruction patients. What I would say about nipple reconstruction is that formal nipple reconstruction, where you actually make the tube of the nipple, the tip of the nipple, is not necessarily appropriate for all patients. And patients with implant-based breast reconstructions who have been radiated you have to be careful who you select for nipple reconstruction, because you can have complications with the reconstruction of the nipple that can lead to a problem with the implant or loss of the implant. And that's rare, but we're very conservative about formal nipple reconstruction in a radiated patient with an implant. But the nipple tattoo for those patients is great. And with these 3D nipple tattoos, to be honest with you, it looks very similar. And we have a lot of patients that say, you know, I'd like the nipple, but I don't want to, you know, at this point, I don't want it to be seen through my clothing. I don't need to have the little tip of the nipple. And the 3D tattoos solve that problem entirely. They look amazing.
You know, what would happen, I guess the question was, is if somebody had thin skin, are they at risk for doing like and getting the 3D nipple tattooing? Or do you think they should consult again with their plastic surgeons over the years? You know, obviously as some of us haven't had, you know, I guess some of us have had thinning of the skin, right?
Yeah.
Like, is that
There,
an
there's
interference?
Yeah, there's definitely a subset of women where the skin is very thin and you would be concerned about it. I would say in general, a professional tattoo by a professional tattoo artist is an intradermal tattoo, meaning it doesn't go all the way through the thickness of the skin. And so those are very safe. You know, I don't do tattoos because I just personally, I think plastic surgeons do a bad job at tattoos. And, you know, we wonderful tattoo artists like we're blessed to have. There's no reason for me to do them. And when you have a professional tattoo artist doing them, they're very safe, and they're intradermal. But yes, there is a small subset of patients where you would want to evaluate and make sure that the skin is not too thin. In the cases that the skin is too thin for tattooing, you know, it's probably too thin for the implant that's underneath it too, and needs some other dressing.
You know, as we're closing out, I do have a question. I want to see what your advice would be to somebody who you've seen in your office. What should they prepare themselves to ask their plastic surgeons if they don't have the chance to see a Dr. Medina who does implants, flat closure, you know, deep and all these procedures? Because as you and I know, not every plastic surgeon's the same, and not every plastic surgeon does a DIEP versus implants. And I think that that's where a miscommunication is in our community. And
Yeah.
again, you know, before you came on, I said in 2004 there was no deep. You know, in 2015 they were doing them, but they weren't very well known or very well spoken about. And now here we are in 2001, and basically they're available, you know, in most states, and most physicians offer them. But what would your advice be is if it was your wife or your mom, you know, walking into a physician's office, sitting with you, like what would you prepare them to ask?
Yeah, I think it's important that you're treated in a high volume center. And I think that's important from both the breast reconstruction standpoint and the treatment standpoint. You know, it doesn't necessarily need to be Miami Cancer Institute or Memorial Sloan Kettering or MD Anderson. You know, there's a lot of high profile names out there, but you do want a center that is doing this routinely, that is doing hundreds of these cases a year, that has a tumor board that's going to discuss, you know, all aspects of the treatment, that you have an integrated team. So I'm always on the phone with radiation oncology about, you know, planning. Are we filled? Are they happy with where we are? Are we happy with how the skin looks? You know, that we have coordination. So when patients are coming off chemotherapy, they're coming back to us to start talking about the next stages. It's just, you want a good integrated team. And then you want to make sure that your plastic surgeon is doing these cases a lot, even on the implant side of these things, because I think the implant side, you know, sometimes gets overlooked with the D flap. The D flap, you definitely want an experienced microsurgical team. That is for sure. For other autologous reconstruction, you know, the technical factors are lower, but for implant-based breast reconstruction, we see a lot of implant-based breast reconstruction cripples who have been through 10, 12 operations for results, and at some point maybe the implant is no longer the right thing for them, or that they were just in a center that didn't have the experience to mitigate risk. You know, we always talk about infection risks. We're always studying our infection risks here. That's always a major issue with implant-based breast reconstruction. So on microsurgery side, you want to know what the flap losses are, what the surgeon tells you, what, you know, flap loss rates are. And then on the implant base, you know, what is the loss of reconstruction rate for infections or complications with skin? You want experienced breast surgeons, because I can get away with a lot when I have a good breast surgeon. You know, if a breast surgeon leaves me a very good mastectomy flap, it takes a lot of the pressure off of me. And then if I have a mastectomy skin flap that is not great, then the stakes are much higher. Those are all the little nuances, and that's the reason to be in a center that does this a lot versus sort of a community based. You know, my plastic surgeon is in this one office, my chemotherapy group is a different private group, and then they refer to somewhere else for radiation. You know, it's worthwhile when you talk about cancer care to have an integrated approach.
We have a question. What about women who are overweight? Does this limit their options?
It depends. So I think the cutoff rate for, you know, everyone has a little bit of a different philosophy with high BMI patients for flap reconstruction. So my cutoff rate tends to be around a BMI of 40. You know, we have done patients with deep flaps that are above BMIs of 40. The risk factors are complications with wound healing and also making sure the patient is up and around and walking and active after surgery, because there's always an increased risk of blood clots in the lungs or the legs in that setting. So high BMI patients are always a little bit riskier. They're also a little bit riskier for implant-based reconstruction, collecting fluid around there, infections, problems with the skin. So optimum weight is always beneficial for every patient, but you know, as far as strict cutoffs for whether or not you'd be a candidate at all for breast reconstruction, we tend to take that as a patient by patient, because you can have some high BMI patients that are otherwise generally well and you can get away with things, or you have some high BMI that have a lot of medical comorbidities and say, you know, maybe the right thing to do right now is a flat closure, get you healed, make sure you don't need any additional treatment, work on weight loss, and then come back and do the breast reconstruction. And even without weight loss, when you do a flat closure and then you stage these operations for a high risk patient, you can have good outcomes that are much less risky by separating it. So you know, when you put all of these operations together, that's when the risks go up, and that's when you want to have a more optimized patient.
Perfect. Well, a couple things I'd like to close out and end on. First, Dr. Medina, thank you so much for joining us this morning. As so many women were looking forward to this call. And again, you know, as we've spoken in the past, I'm a huge advocate of knowing your breast reconstruction options. And I think this morning we touched base on all of them that are available. So if anybody has more information, more questions on Know Your Breast Reconstruction Options, you can go to www.brcastrong.org. Know Your Breast Reconstruction Options is on there. Everything that is available from A to Z up until 2021. Second is this morning at 11:30, we have the Pink Run with Miami Cancer Institute with Dr. John Diaz and Dr. Star Martiner. So we will be on back at 11:30. Super excited for that program this morning. If anybody's interested in seeing Dr. Medina or seeking an opinion, you are welcome to go ahead and follow Miami Cancer Institute. Dr. Medina has his page that he just opened. So if you guys are interested in seeing him or finding more information, you can either contact myself or Miami Cancer Institute. His first name is, again, Dr. Miguel Medina. And last but not least is coming to the last 2 weeks of October, and everybody's bringing awareness in our community. You know, I wanted to touch base on pink washing and just bring awareness that BRCA Strong is a grassroots foundation touching women's lives every day in person, basically either delivering packages or sending them mail all over the United States. We're here if you need a pre-mastectomy care package or post-mastectomy garments, such as lymphedema sleeves, bathing suits, prosthesis, and post-mastectomy bras. So if we're able to help you at any time, you can please feel free to reach out to myself or any of our board members. And again, Dr. Medina, thank you so much for coming on, and we will have you back on soon.
My pleasure. Thank you very much for having me.
Perfect. Have a good day.
Take care.